Hello, I'm Renato Ambrósio from Rio de Janeiro, Brazil. I'm happy and grateful for participating in the 6 meeting. I thank my brother, Durval Carvalho Júnior, who is there with you moderating this session, and Ahmia Ashraf for the nice invitation to participate. So my topic is one of the main work that I'm doing, which is diagnosis of corneal ectasia paradigm shift. I work with different companies, including, of course, Oculus, and also I'm the CEO of Brain, Brazilian Artificial Network in Medicine. And also we are starting an Ambrosio Vision Academy with a lot of content that you may be interested in the future. When we think about refractive surgery, we have to quote the ISRS, the International Independent ISRS, International Society of Refractive Surgery, with many big I's, including innovation, impact, inclusivity, and inspiration. So I invite all of you to join the ISRS.online. And this is the editorial that I put together with our current president, Dr. Dipinder Dhaliwal from Pittsburgh, United States. When you think about ectasia, the what's and whys, it's different when you screen ectasia risk prior to laser vision correction with enhanced screening. And when we manage patients with ectasia prior to keratoplasty, we broke paradigms and we create some paradoxes. But enhanced screening for ectasia susceptibility is different than diagnosing ectasia, is different than classifying and staging the disease, giving prognostic factor, and also the clinical individualized management and follow-up. For example, when we classify the thinning pattern that we have from the consensus on the thinning location in pellucid and keratoglobus that is different than keratoconus, we need tomography. And this is not a it's a false pellucid, I would say, is an inferior cone. There is no thinning, as you see here, in contrast with this situation. And it's not only an academic quote for the classification, but it changes the management, it changes the prognosis. So we need to think about topography evolving to tomography, and this evolution is a true revolution in corneal imaging. Interestingly, we also evolved to biomechanical assessment. I'm honored to collaborate with colleagues like Paulo Vinciguerra, Ricardo Vinciguerra, and Cynthia Roberts, El Sheikh Ahmed, Bernardo Lopes, and the Corvus takes in this videos for characterizing the velocity and the deformation shape of the cornea. And we have AI so that we can get the corneal biomechanical index from the Corvus. And we characterize if the cornea is softer or stiffer. So when we think about imaging, it goes with a plethora of diagnostics, including topography, imaging of the ocular surface, Scheimpflug, OCT, tomography, whole eye wavefront analysis, axial length, specular and confocal microscopy, going to genetics. And with this amount of information, AI came into very big relevance, because we need to apply AI so that we can use this work. Managing keratoconus goes from diagnostics to patient education and clinical treatment and surgical treatment. The first thing that we broke a huge paradigm shift is the importance of telling people not to rub the eye. Eye rubbing is a major cause of disease aggravation and even causing the disease. And my colleague and friend, Damian Gatinel, he put together a very nice work on the sine qua non for keratoconus. But I would say eye rubbing is sine qua non for corneal ectasia, secondary corneal ectasia, but the primary keratoconus is aggravated by eye rubbing. And the difference between aggravating keratoconus and causing ectasia is very important for prognosis. We also have data from whole eye wavefront data for a super auto refraction, so that we can optimize manifest refraction, like in this case, improving up to 3 lines of distance correct vision, as I see in my daily practice. Imaging can also help improving contact lens feeding, like in this case that had indication for keratoplasty. We did corneal rings, we did corneal cross-linking, but they still need some visual rehabilitation. And here the scleral lens assessed by OCT is very important. But it's important that we understand that it does not slow progression of ectasia. Contact lens gives you the best vision, and also the consensus gave us the line that for cosmetic or elective reasons, we should be careful in using contact lenses. When I did my training with Professor Siventhal, my colleague and friend Durval Carvalho was also a resident of Dr. Siventhal. We only had keratoplasty. We evolved to lamellar keratoplasty, but now we have much more procedures in this huge paradigm shift that we had. We have corneal cross-linking. It's not collagen cross-link, it's corneal cross-linking. Brilliant work led by Theo Seiler and his group in Dresden. I do believe it's truly an honor that deserves a Nobel Award, but we need to think about when and how to do corneal cross-linking. Also, corneal ring implantations. Paulo Ferrara, our good friend from Brazil, and Professor Colan, our past colleague, they did great contributions for corneal ring implantations in keratoconus. And now we have CARES, we have different types of technologies for implantation of tissue and synthetic tissue and processed tissue for keratoconus and ectasia management. And this gives us the opportunity to think about therapeutic refractive surgery, which is not the same as elective refractive surgery. And we have to distinguish because therapeutic refractive surgery aims to improve distance correct vision and rehabilitate so that patients do not need keratoplasty, and in contrast to elective procedures that patients want visual rehabilitation without glasses and contact lenses to improve quality of life and quality of vision. So it's important of patient education for proper expectations. And this multimodal diagnostics is a paradigm shift because when we screen a population, like when we do a screening test in the university that I work here in Rio de Janeiro at Unirio, we did a very nice study that we included 512 people that had no diagnosis of keratoconus, and we did pentacam and corvis, and we found about 13% of patients with mild to moderate keratoconus. Interestingly, we characterize ectasia susceptibility for laser vision correction. We confirm the disease. We do the staging, classification, prognosis, and individualized measurement for clinical follow-up. So I'll give you an example. This 13 years old with keratoconus in the left eye had a normal topography in the right eye. So how the exams can help me? They can help me first identifying that this mild disease in the right eye. You see the TBI is abnormal, but also in the left eye, the low SPA1, this is Cynthia Roberts parameter, would confirm a high indication of disease progression, high risk of disease progression. This patient came back 6 months later. He decided not to do surgery. Kmax has reduced, but there is a steepening. You see steepening in the second visit, and this is in accordance with the Bell and ABC and lucid dysrect vision. So we need to do surgery as soon as possible. Otherwise, we are losing opportunities. When we think about the pathophysiology of ectasia, we have to consider corneal resistance and the biomechanical cycle of decompensation that any cornea can undergo. And of course, laser vision correction procedures would weaken the cornea. And we need to be keen on understanding beyond corneal topography, beyond the diagnosis of keratoconus for characterizing ectasia susceptibility. This is one of the cases that we use a lot. This patient had ectasia after LASIK with a thin flap, and you see the D, which is abnormal along with Artmax. Also, my friend Tarek El Nagar from Egypt, he did a very nice publication on a case that had smile-induced ectasia, and we found that this patient had low K keratoconus based on many of these parameters, including the D that is abnormal. So keratoconus can happen with a low K, relatively low K, actually in about 10% of cases. The K max is lower than 47. Interestingly, we have to look at a larger population, and even the Pentacam random forest index, we see that there are cases that we need to evolve, and this is a work that we have to go for epithelial thickness, biomechanics, and the revolution of epithelial thickness and OCT. We have now the Pentacam OCT, which has Scheinflug and OCT spectral domain together. And we have a huge resolution, a very nice 1.9 micron resolution, and we can do epithelial thickness mapping. And this very asymmetric ectasia here, we can see that the epithelium is abnormal. The law of Reinstein on epithelial thickness is related to filling depressions, thin over the peaks, and this is proportional to the rate of change. This is a secondary change, not the primary change. Maybe the primary change is genetics and molecular biology, as the great work by Hodge Shetty, but the impact from surgery should also be considered. The RTA, the relational tissue altered, would consider age, thickness of the thinnest point, and the flap and ablation, or the cap and smile. When you have an ROC that's statistically better than residual stromal bed and the PTA. So the enhanced ectasia susceptibility score will tell us with a brain analysis, and it will go back to the basis of medicine, primary node area, so that we can evaluate patients for candidacy of laser vision correction in this paradigm shift that uses AI and advanced diagnostics. So thank you very much for the honor of participating in this great session, and I look forward to collaborating with you in further discussions. Thank you.